Well, we're going to start today with the muscular system. Greetings. This is the Chapter 10 lecture involving the muscular system. We're going to get through a lot of different muscles. I do encourage you to take the time to review the chapter text and begin, yes, the memorization, etc., because it's going to be absolutely essential that you know many of these muscles, their names and their locations, and in some cases, their absolute functions. Well, let's get started. Now, skeletal muscles make up almost half the weight of the body. Now, that's skeletal muscles. And the muscular system is divided into axial and appendicular muscles. If you remember, axial is for support and position of the axial skeleton. The appendicular is for the support and for movement and to help brace the limbs. Now, skeletal muscle fibers contract the same, but the variances in performance depend on muscle fiber organization and how the muscle is attached to the skeleton. You have to keep both of these in mind, especially when you start coming up to situations where you're talking about how the forearm affects the movement of the fingers and the hands, the shoulder, and how that plays a role in the muscle movements of the upper arm, and also some of the musculature that's in the hip, etc., and how that plays a role, and of course the lower leg muscles and how they play a role in the movement of the foot and toes. Now you notice here that they're saying muscular system 44%, integumentary system 16%, skeletal system 20%. Okay, so this is the amount of mass. Keep in mind a couple of other things. Besides the division here of axial muscles and appendicular muscles, you have to keep in mind the attachments via tendons and aponeuroses, because these are going to conduct the forces of contraction to perform specific tasks. Now, muscular power and range of motion, ROM, are influenced by fascicle organization and leverage. Fascicle organization. What we're talking about here is what is the orientation of the collection of muscle fibers that make up that muscle. For example, if we talk about parallel, the fascicles are parallel to the long axis of the muscle. The muscles can be flat bands with aponeuroses at each end. The others are basically plump, cylindrical with tendon. Remember, the tendons are cord-like structures. And these attachments are going to be on one or both ends. These muscles have a central body. A lot of times we call that a belly. Okay? Now, convergent muscles, these are the fascicles, extend over a broad area and converge on a common attachment site. When we talk about pennate muscles, penna is another term that means feather. So the fascicles form a common angle with the tendon. So it's sort of like, if you can think about this, whenever you look at a feather, you have that central shaft, and off of it come the fine parts of the feather, okay? All of what they would call the rays or the fluff. Now, fibers pull at this angle, but the reduced pull is compensated by the greater number of muscle fibers present, so the tension's greater. Now, you need to know the three types: unipennate, bipennate, multipennate. Unipennate, the muscle fibers are on the same side of the tendon. Bipennate, the muscle fibers are on both sides of the tendon. Multipennate, the tendon branches within the muscle. And then we have circular muscles. Now, these are also referred to as sphincter muscles. So don't just think of sphincters as something that you would see in either the digestive system or in the anus or something else like that, because really, circular muscles you're going to find in the orbicularis, oris, the orbicularis, oculi. The fascicles are concentrically arranged, and they encircle a duct, a tube, or an opening, such as an eye, a mouth, etc. And when the muscles contract, the diameter of the opening will decrease, or as you might call it, constrict. So let's look at this. Now, here are the fascicles. And this would be the wide part here, so this is going to be the body or the belly of the muscle. Now, if on the other hand, if you take a look here, and you can see how all the fascicles are arranged and they kind of fuse up at one tendon. That's what you're going to see here. Then we get into the pennate type of musculature. And that's where you would see unipennate, and it has, this is the extensor digitorum muscle. Notice that they're all attached on just one side of that tendon. Whereas the rectus femoris muscle, you have a bipennate. Now, yes, you've got the tendons here and here, but don't get confused with that, because look at what you have here, where the muscle fibers are attached, as if the tendon is right through the center there on both sides. Now, if you look at the deltoid muscle, you have the tendons going through this at 3 different sections. So that's where you would have a multipennate muscle, which then would basically add up to a massive muscle force as these tendons fuse together down here. Then we have the circular muscles, and you can see this if this is contracted, and then if we relax it, you notice that the lumen, the aperture here, is opened up much greater. Now, the force, speed of direction of movement produced by the muscle contraction can be modified by attaching a muscle to a lever. And what is a lever? This is a rigid structure used to lift or pry something that pivots on a fixed joint, or excuse me, fixed point. The fulcrum is the fixed point where the applied force is occurring. The lever moves when an applied force, and that's where you've seen this in diagrams, AF, applied force, is able to overcome any load that prevents movement. Now, in the body, the lever is usually the bone. The joint is the fulcrum, and the muscles crossing the joint provide the applied force. So you would see this. Now, there are different classes of levers. First class, second class, third class. First class, the fulcrum lies between the applied force and the load. And neck extension is an example. Second class lever. The load is located between the applied force and the fulcrum. And this is because of distance between the applied force and the fulcrum is greater. The load moves slowly and only for a short distance. The plantar flexion at the ankle joint is an example. Finally, the third class lever. This is the most common lever in the body. The applied force is between the load and the fulcrum. Speed and travel are increased at the expense of effective force. An example of this, the biceps brachii flexion is an example. So here we go. First class here. The fulcrum, the load, the applied force. So what is the load? The load is really the weight of the skull. The applied force is coming from the spinous capitis and the semispinous capitis muscles. Now, where is the fulcrum? The fulcrum is right here, okay, at this joint, the extension of the atlanto-occipital joint. Here, this is the wheelbarrow analogy. This is a second class lever. You have the fulcrum here, the load is here, and the applied force is a distance away from both of these. So what you would see here is the fulcrum is where the toes are, okay? Or basically the plantar flexion at the ankle joint, okay? Now, the load is right here. The applied force is up through here by the gastrocnemius muscle. As a result, it causes the change. As this muscle contracts, and notice that it is attached to the Achilles tendon here, which was going to be attached to the calcaneus, it's going to cause a lifting force. Now, the last one is the third class, which is very common in the body. You have, of course, the fulcrum, the applied force, and the load. They use an example of tongs. Let's use the example of biceps brachii muscle. Now keep in mind that we've talked about this before. Origin, insertion. So where is this inserted? That's where the bones are going to move. Okay. So the applied force is the contraction by the biceps brachii muscles. The fulcrum is really at the elbow joint here. And so you're going to have flexion of the elbow joint because this is the load. And so when this occurs, this applied force, it is going to raise against the load. Okay. Now, I mentioned before what an origin is. An origin is the muscle attachment site where the bone or structure does not move. The insertion, this is the muscle attachment site where the bone or structure does move. Now, all of you are probably wondering, do I got to memorize every origin and every insertion of every muscle? No. If I do mention it in these PowerPoints, yes. But if you were doing kinesthetics, if you were doing more in the PT area, you might have to, just to give you a heads up. But where I do mention it, it's fair game on the exam. The action, that's the specific movement of the muscle. In complex movements, muscles work in groups. Now, when we talk about several of these players, we always have sort of a central figure and then some that help and some that stabilize and some that oppose. So let's go through them. Agonists, synergists, fixators, and antagonists. The agonist is the prime mover. This is the muscle whose contraction is primarily responsible for producing a specific movement. If you want the forearm flexion, that's your biceps brachii. Now, a synergist, syn means together, ergon, work. This is where you have a muscle that upon contraction helps a larger agonist work more efficiently. Fixators, this is a synergist muscle that assists the agonist by preventing movement at another joint. Okay, this can happen. You have to have something that acts as a stabilizing factor so you don't have other joints come into play here. The antagonist, this is the muscle whose movement opposes that of another muscle. So, for example, in your upper arm, you have the triceps brachii, all right? And then you have the biceps brachii. Triceps has to relax for the biceps brachii to contract and effectively move the forearm. Then you can have the extension of the forearm where the triceps brachii contracts and the biceps relaxes. So that's the agonist-antagonist. You're always going to have one contract and one relax. And you can see this action here. Here the origin of the biceps brachii. You don't have to worry about any movement there, but this is where it's attached to. The insertion here, so that this muscle is going to contract, and when it does, you're going to have the action of a flexion. Now, what do you see here? You see several different players here as they begin to bring in other muscles of the arm. Your agonist or prime mover, and this is for the action of flexion at the elbow. You're going to have biceps brachii. Your antagonist, that's the triceps brachii. Okay? Now your synergist for flexion at the elbow is going to be the brachioradialis. It is origin is up here at the humerus, and its insertion is down here. Okay, so this is the radius muscle. Excuse me, radius bone. I'm sorry about that. Now, there's a chart in a minute. You're going to get information on appearance, location, and/or function. I absolutely insist that you take the time to review it, memorize it. If you have to use index cards, whatever is necessary, you need to get these prefixes, suffixes, and terms down because they will provide you with a vast quantity of information that will help you to translate any muscle, the name of it, into where it's located, what its shape may be, what is its function, etc. So terms indicating specific body regions, you have the abdominis, which was abdomen, excuse me. And you can go all the way down through here to ulnar. Now you notice that a lot of these are going to use terms that you've already dealt with. If you remember your anatomical terminology in Chapter 1. Okay? Cervicus, hallucus, great toe, pollis, thumb, okay? Temporal, the temple, etc. Terms indicating position, direction, or fascicle orientation. Anterior, posterior, lateral, medial, oblique, rectus, superficial, okay? Extrinsic, intrinsic, transverse, etc. Terms indicating structural characteristics of the muscle. Nature of origin, is it biceps 2 heads, triceps 3 heads, quadriceps 4 heads? Shape, triangular, deltoid, orbicularis, circle, platy, flat, pyramidal, pyramid, serratus, serrated, just like a serration of blade on a knife, trapezius, trapezoid, teres, long and round. Then you get other striking features. Alba, white, gracilis, slender, latissimus, widest, longissimus, longest, magnus, large, major, larger, maximus, largest, minimus, smallest. So if you put these together, you're going to be able to understand a great deal. And then finally, the terms indicating actions. An abductor moves away. An abductor moves away. Adductor moves toward it. Depressor, extensor, flexor, levitator, raising movement. Supinator, pronator, tensor, and then the specific ones. Buccinator, this is for the trumpeter. Because if you've ever seen, let's take Dizzy Gillespie or some of the other famous jazz trumpeters, you'd see these big, big cheeks as they're belting out that music on that horn. And that's where the buccinator, the trumpeter, comes from. Risorus is laughter. Sartorius, like a tailor. Remember I told you about the cross-legged approach there of the tailor. So you have this long muscle that allows for the cross-legged position that they would arrange to do their work. Now, so you have to really take time to really review those terms. Now, the skeletal muscles can be assigned to the axial division or appendicular division based on origins and functions. Axial muscles, as I said, arise from the axial skeleton and encompass about 60% of the skeletal muscles of the body. Function is to position head and spinal columns, move the rib cage, assist in movements such as breathing. Now, the appendicular muscles, they stabilize or move the appendicular skeleton and encompass 40% of the skeletal muscles of the body. Their function is more to stabilize or move upper and lower limbs. Now, this is again, in part, memorization. This is also in part a means to give you to start reviewing structures here, because they will eventually come back to you later on, not only in your clinical or allied health studies, but also in AP2, etc. As you can see here, the axial muscles include such things as the temporalis and the occipitofrontalis. This is also called the occipitofrontal muscle, which has two bellies, really. The frontal belly is here, the occipital belly is back here. You have the aponeurosis over the top of the head, okay? Sternocleidomastoid, the rectus abdominis, the external oblique, the linea alba. Now, we're going to get into all of these structures, and you need to be aware of them. Oh, by the way, there is the platysma, which is that flattened one, but they have pulled that away. But we're going to get back to that in a bit. Also, there's going to be some remarkable and very important tendon or stabilizing tendons that you need to be aware of. For example, the calcaneal tendon, commonly called the Achilles tendon. So we're going to go through axial muscles, then appendicular muscles. If you notice, there's a lot of these located here, but this is how you're able to do things like raise your arms, raise your legs, move your toes, move your fingers, move the arms and legs in a coordinated fashion, etc. Axial skeleton consists of 4 groups. Head and neck muscles, including those attached to the vertebral column, which include facial muscles, extrinsic eye muscles, muscles of the tongue, pharynx, and neck. Muscles of the vertebral column. Their function is to help stabilize, flex, extend, rotate the vertebral column. The oblique and rectus muscles of the body trunk, which comprise broad sheets or bands that form the muscular walls of the thoracic and abdominal pelvic cavities. Finally, the muscles of the pelvic floor that span the pelvic outlet and support the organs of the pelvis. So we're going to go through this first and then go in the appendicular. Now we have muscles of facial expression. These are important in eating and communication. Muscles of facial expression originate on the surface of the skull, except for the platysma of the neck. And the fibers of the epimysium insert. They're actually woven into the superficial fascia. That's the subcutaneous layer. Or they are inserted into the dermis of the skin. So you have several different approaches here. But upon contraction, the skin moves. You want to also note that the sphincter muscles of the orbicularis oculi, for the eye, and the orbicularis oris of the mouth play important roles here. The occipital frontalis muscle has 2 bellies, the occipital belly and the frontal belly, which I have shown you. They are connected by a cartilaginous sheet called the epicranial aponeurosis. Here's the epicranial aponeurosis. So think about it this way. You've got a muscle here and a muscle here. You've got this connective tissue here, and then on the back side, you're going to have the occipital belly of this same occipital frontalis. On the sides here, you have the temporalis muscle. You have the circular muscles of the orbicularis oculi, the orbicularis oris. You also have a variety of other smaller muscles involved with facial expression, etc. The corrugators supercilii, the procerus, right here, the nasalis, the zygomatus major, and the zygomatus minor. This is the major, this is the minor. The risorus is right here. Here we have part of the platysma, which rolls over, and then we have the mentalis right here. You have the masseter here and the buccinator right here. The depressor angular oris is right here. The depressor labii inferioris is here. Now, notice that this is where the thyroid cartilage of the larynx is. The platysma kind of is on the surface, so it would be considered superficial, but if we pull it away, we go deep, we're going to start seeing the sternocleidomastoid here, plus other ones that are attached to the clavicle. If you notice on the side here, as I mentioned, the occipital belly, the frontal belly, the nasalis. We've gone through most of these other muscles, except we didn't mention as much the depressor labii inferioris here, the depressor anguli oris right here. Okay, temporalis is here. You're going to notice that there's an aponeurosis approach right here, and then we have the masseter right here. Now, you're going to have a variety of muscles here. I would not insist that you know all the origins and insertions. I give this to you to get familiarized with them only. But it is helpful if you go through these muscles and know what actions they do. All right? Then, we're going to look at the extrinsic eye muscles and the muscles of mastication, chewing. 5 of the 6 extrinsic muscles are on the left image. That is the superior oblique, superior rectus, lateral rectus, inferior oblique, inferior rectus. The 6th muscle can be viewed on the right image, and that's the medial rectus. Bones of all eye muscles are located in the orbital bones, or the origins of them are located in the orbital bones, either the sphenoid or the maxilla. Bones of mastication include the masseter, the temporalis, and the pterygoids, both medial and lateral. So on this side, you can see 5 of the 6. Why? Because The rectus is on the other side. So you have the lateral one here. You have the medial one here. Okay? You have the superior oblique, superior rectus, inferior oblique, inferior rectus. All right? Notice that they all somewhat attach back here. They have an attachment onto the sclera of the eyeball there to allow you to move around. You also have a levator palpebrae superioris right here. Okay? Now, one other cutesy little thing, or kind of important, but it's sort of interesting that you have this superior oblique that passes through this little loop of connective tissue here so that you can move the eyeball in different angles, and that's due to its attachment to the trochlea, and so it will pull on the eyeball. All right? Now, if you look on the side, this is the muscles of chewing. You have the masseter here, and part of it is attached up here. So basically, it allows the mandible to come up to the maxilla. But two other ones that are extremely important are the medial pterygoid and the lateral pterygoid. And these are somewhat on the inside of the mandible. You will notice that you have a superior temporal line here. This is really where this muscle is directly attached to the bone. This is more the aponeurosis. And you also notice the capsule here of the temporomandibular joint. Now, we've gone through all of these muscles here. We've gone through these muscles, get an idea about their actions. It is important that you get some idea about origin. Insertion for all of these eye muscles is basically into the eyeball. That's going to cause it to move. The origins, you can pretty much work out that the origins are all going to be into the sphenoid except for the inferior oblique, which is in the maxilla. Okay? Muscles of the tongue are associated with the muscles of the pharynx and neck. The tongue muscles include the palatoglossus, the styloglossus, the genoglossus, the hyloglossus. Glossus refers to the Greek, and that refers to the tongue, speech. So it depends where they initially attach to. The hyoid bone, the styloid process, etc. It is important for you to keep in mind that you have the hyoid bone and the styloid process present. The pharynx muscles, you have pharyngeal constrictors, which constrict the pharynx to propel ingested food mass into the esophagus. You have a laryngeal elevator, which elevates the larynx, and the palatal muscles, which elevate the soft palate. So, here are our muscles of the tongue: paloglossus, styloglossus, genoglossus, and hyoidglossus. Notice that several of them attach to the hyoid bone. This one, the styloglossus, attaches also to the styloid mass process of the skull. That's that little pointy bone. Then, interestingly enough, it also is an anchor for the laryngeal elevators, here and here. Excuse me. And these bones, these muscles here, here, and here play a critical role in the pharyngeal constrictors. Here underneath is the esophagus. I would encourage you to go over both origin and insertion as well as action of these muscles here. Okay. Now, when we talk about the anterior muscles of the neck, are primarily involved in the positioning of the mandible, hyoid bone, and larynx. Let's talk about these muscles here for a minute. The floor of the mouth muscles is the mylohyoid and the digastric. Now, the digastric is consisting of an anterior belly and a posterior belly, and the geniohyoid. There are small muscles of the hyoid, the stylohyoid and the thyrohyoid. The muscles originating at the sternum include the sternothyroid, sternohyaloid, and the sternocleidomastoid. Several muscles extend from the hyoid. to the mandible that form the muscular floor of the mouth and support the tongue. You want to note also that there are attachments to the styloid process, hyoid, and the sternum, such as what you see right here. Okay, here is the mylohyoid, and if you cut and reflect it, you can see better the stylohyoid here and the thyrohyoid here. The digastric you have is the anterior belly and the posterior belly. You have here cut and reflected the sternocleidomastoid, but you also have the omohyoid, which has its superior belly here, and the inferior belly here. There's sort of an attachment structure here that eventually leads to the clavicle and to the sternum. And you can see this sternocleidomastoid extension right here. You have the sternohyoid right here and here, so it's attached to the sternum moving upward. The sternothyroid is right here. Okay. If you look down into the mouth, here's your mandible, here's your hyaloid bone. You have the genohyoid here and here, the mylohyoid here and here, and the genoglossus here. What do? That's what I want you to review. Digastric will elevate the mandible and elevate the larynx. Genohyoid as above and pulls the hyaloid bone anteriorly. Mylohyoid elevates the hyoid bone or depresses the mandible. The omohyoid depresses the hyaloid bone and larynx. Sternohyoid depresses the hyaloid bone and larynx, and again the same thing with the sternothyroid. The stylohyoid elevates the larynx. The thyrohyoid elevates the thyroid, depresses the hyoid. The sternocleidomastoid flexes the neck. One alone bends the head toward the shoulder and rotates the neck. And what I mean by that is just one side is necessary. Why are we all talking about this? Because one of the things you have to think about is this. If you were just to focus on this part of the body, let's say someone is completely paralyzed, but they can eat, communicate, things like that. These prevent them from aspirating their own food, because you have to elevate the larynx, close up, and allow food to go down the proper means, and that would be going down into the esophagus, having food go down the right route. Whereas you're going to close up the airway so that nothing gets in there. Now we're going to start moving into the vertebral column. And basically the function is to support and align the axial skeleton. Now the muscles here are going to be arranged in several layers. They will include muscles that originate or insert on the ribs and processes of the vertebrae. Remember, this is where we have the transverse processes, the spinous processes, etc. The spinous extensors are on the superficial layer. They include the splenius, both the splenius capitis and the splenius cervicus. You can kind of tell. Splenius capitis has got to do with the head. Cervicus is the cervical vertebrae. The erector spinae are divided into three groups. The spinous group, the longissimus group, and we'll get into that last one in a minute. But the spinous group includes the spinous cervicus, the spinalis thoraticus. The longissimus includes the longissimus capitis, longissimus cervicus, and the longissimus thoraticus. And then we have the last of the three groups. This is the iliocostalis group, which includes the iliocostalis cervicus, iliocostalis thoraticus, and iliocostalis lumborum. You can see where that's going down the spinal, the vertebrae groups. Now, in the deep layer, we have these spinal extensors. Excuse me. And they're going to be referred to by the semispinalis capitis, cervicus, thoraticus, and then there's one called the multitifidus. Okay. Then we have spinal flexors. Now remember, flexors is to bend, extensor is sort of like to increase the angle, or in a way, straighten up. The spinal flexors are few because many of the large trunk muscles flex the vertebral column when they contract. Most of the body weight lies anterior to the vertebral column. Also, gravity tends to flex the spine when unopposed by the extensor muscles. So these will include the longus capitis, the longus colli, and the quadraticus lumborum. So let's take these groups first, going by the superficial layer. The spinalis capitis, okay, the spinalis cervicus here. The longissimus capitis is here. So all of these are attached either to the head or they're going to be attached to the neck. And we're going to get into that in a minute. If you look, you will go longissimus cervicus, iliocostalis cervicus. Here, iliocostalis cervicus. Here and here are the longissimus cervicus and the iliocostus thoraticus here, longissimus thoraticus here. So it's as if we put this as a straight line. Certain sets are closer to the vertebrae, others are farther away. And also they may be attached also instead of to the vertebrae, they're attached to the ribs. Okay, if that helps you. Longissimus thoraticus, spinalicus thoraticus here, iliocostal lumborum right here. Now, the erector spinae muscle group. This is the spinalis, longissimus, and iliocostalis. There we are, the three sets right there. If you'll notice also, the spinal extensors, the deep layer, semispinalis capitis up here, semispinal cervicus right up here, semispinalis thoraticus right here. Now these are deep. These are more on the superficial layer. Okay. The multifidus is right down here. And by the way, when we were talking earlier about muscles of the anterior cervical spine, longus capitis are here. Longus colli are here. Okay. The quadraticus lumboricum right here. Basically, it's attached. Don't you find that interesting? It's here at the crest of the ilium, but it goes all the way up to basically only the 12th or floating rib right down here. All right? Now that's the posterior view. This is something that, again, this is lots of information, and I don't expect you to know all the origins and insertions, okay? I would encourage you to try to review some of these, where they're located, and what is their action. Now, we have the oblique and the rectus muscles form the muscular walls of the trunk. Their key actions include elevate and depress the ribs, compress the abdomen, compress the abdominal cavity or the thoracic cavity. So we're going to break this into the two groups. First, the oblique group, which is the cervical region. You're going to see the scalenes. The thoracic region, you're going to have the internal, external, intercostals, and the transverse thoraticus. These are also important when we talk about breathing later on. Respiration when we get into A and P2, for example. And then we have the abdominal region, which is the external oblique, the internal oblique, transversus abdominis. These are all flat sheet-like muscles. Then we have the rectus group, which has the thoracic region, and that's just the diaphragm. And then the abdominal region, and that's the rectus abdominis. And you can see how these two groups are broken up. Again, this is where I'm telling you, you don't have to have origin and insertion memorized, but I would encourage you to know where these are located and what is some of their functions. Okay. Here is an example of the scalenes here, and notice that they're attached very early to the ribs, rib 1, rib 2, okay? Then you move into the flattened muscles. The anterior you would see here, you would have, of course, external intercostal, internal intercostal, serratus anterior. Notice that you would have the erector spinae group right through here. And here is the external oblique. You have some costal cartilages here because this is at basically the border between the abdomen and the thoracic region. So you have the xiphoid process here, and you have the rectus abdominis here and here, okay? Notice, and you can't miss it, is the central tendon of the diaphragm. So this is the diaphragm right here. Notice that it has apertures for the inferior vena cava and for the esophagus and for also the thoracic aorta. Now, if we look through a transverse section through the abdominal cavity, what do you see? More clearly, rectus abdominis. You have a rectus sheath on each side here. You have the external oblique, the internal oblique. So external is outside, internal is more internal, and then next to it is the transverse abdominis. And also now we're getting down to the L3 area, so you can see the quadraticus lumborum right here, okay? If this was an interior view, here you have it. External oblique, you have the linea alba right here. You have external intercostal, internal intercostal. They cut away the external oblique so you can see now the internal oblique. So they're like fine, thin, muscular layers on top of each other. Then in the front here you have these structures called the rectus abdominis. This is another view of the diaphragm, but you will notice also that there are the structures that are attached as part of the diaphragm to L4, 3, 2, as well as the 12th rib, okay? There is an impression section, meaning that there's space here, kind of pushes up against it for the stomach, as well as for the liver, all right? And you see how this is also the costal cartilages are around it. Sternum's here, xiphoid process is here. Now, muscles of the pelvic floor support the abdominal pelvic cavity organs. The perineal region is divided by the anal triangle, which we've talked about before, posteriorly, and the urogenital triangle anteriorly. The muscular sphincters surround the openings, the urethra and the anus, and permit voluntary control of urination and defecation. Now, the urogenital triangle consists of superficial muscles of the bulbal spongiosus, both male and female, the ischiocavernosus, the superficial transverse perineal. Underneath that, the deep muscles are the deep transverse perineal muscle, the external urethral sphincter, male and female. Both of these contribute to closing of the urethra. We have the anal triangle, which has a pelvic diaphragm, the coccygenius, the levator ani, which consists of the iliococcygeus and the pubococcygeus, and then we have the external anal sphincter. Here is my urogenital triangle, right here. Here is my anal triangle. Now this is for female, and you can see the same triangles here for the male. Okay? And what you note is, besides the anus, you have here the external anal sphincter here and here. The levator ani, which is consisting of the pubococcygeus and the iliococcygeus, which is here and here, and you see this also on the male here and here. You'll notice that you have, besides adipose tissue, you're going to have the gluteus maximus here, same here. But what we need to really consider is the deep transverse perineal muscle, which is right over here and right over here in males. The central tendon of the perineum, right here, okay? And that tendon is much smaller in the female, okay? The urogenital triangle, the ischiocavernosus and the bulbospongiosus, here and here. And you would see the same thing here and here. And then, of course, you have the superficial transverse perineal right here and right here, okay? So, again, I'm not asking you for origin and insertion all over the place. Do take the time to go over the muscles. Do take some time to go over the differences between males and females, okay, through the superficial and deep muscles, and get an idea of what they're doing. What do these structures actually do? Now we're going to start moving into the appendicular muscles. So they are involved with stabilizing and positioning and supporting the limbs. Now these groups include the upper limb muscles, which include those that position the pectoral girdle, move the arm, move the forearm and hand, the extrinsic muscles of the hand and fingers, and the intrinsic muscles of the hand and fingers. Then we have the lower limb muscles, which move the thigh, move the leg, and then we end up with the extrinsic muscles that move the foot and toes, and the intrinsic muscles that move the foot and toes. So let's get moving. Here's my upper limb. Here's my lower limb. Okay? Keep in mind something, that some of the muscles here are much more massive because, in part, it's not just moving this limb, but it's also supporting weight and structure at the same time. These don't have to do that. All right? So we're going to have the muscles that support the pectoral girdle, muscles that move the arm, muscles that move the forearm and hand, extrinsic muscles of the hand and fingers, intrinsic muscles of the hand and fingers. Okay? And you're sitting there going, so what? What's the difference? Extrinsic meaning really outside. These muscles that contract will cause you to wiggle some of your toes. The muscles that are right in the foot, the intrinsics, play a role in moving the foot as well, and the toes, etc. Same thing here. Intrinsic muscles of the hand help you to make some motions of the hand, but also being able to grasp on something and hold a ball or something else. Part of that is done via the extrinsic muscles of the hand that are up in here, and they have very long tendons that go all the way down into the hand. That's what I want you to have an appreciation for. So let's talk about the largest appendicular muscles originate on the trunk. We're going to start up with the upper limb first and then go to the lower limbs. Now the muscles originating on the trunk control the gross, the large-scale movement of the limbs. Distally, limb muscles get smaller, more numerous, and the movements become more precise. Appendicular muscles that originate on the large bones of the limb girdles and the proximal bones of the limbs dominate the posterior trunk. Compare the superficial muscles and the deep muscles on the anterior and posterior view. I want you to keep that in mind. And then there are some other very important little notes. Serratus is like a serrated knife. The Latin serratere, to saw, referring to the shape. Notice that the serratus anterior acts to pull the scapula forward around the thorax. So here we have this, okay? Remember the platysma, this flat sheet? Notice it kind of rolls over on top of the clavicle? All righty, well, here we go. Appendicular muscles, deltoid, pectoralis major, that's the big one. Latissimus dorsi, it's more on the back there, but here's our serratus anterior. Look here, just like jagged parts of a serrated knife, okay? Then we look up here, after we pulled away the platysma, and we have the trapezius, the subclavius, below the clavicle. The deltoid has to be cut and reflected, pulled back. so that you can see the pectoralis minor, all of this, the subscapularis, the pectoralis major, and that had to be cut and reflected. Then we have the coracle brachialis right up here. The biceps brachii is over here. The teres major is right here, almost under the armpit. The serratus anterior is all the way through here. Okay? Now, we're going to eventually get into the appendicular muscles down here. The biggies, of course, I want you to be aware of are tensor fasciae latae, the sartoris, the rectus femoris, the gluteus medius, the iliopsoas, right here, the pectineus, right here, the adductor longus, which we're going to get into, and the gracilis, which is right here. And then, of course, we've got the quadriceps group, and we'll get into that in a bit. Notice that this is the difference between the superficial dissection and the deep dissection. So when you pull away a lot of the muscles here, you see a lot more detail here, how they play a role and combine to give you movement, etc. Now, when you look at the posterior view, well, the appendicular muscles here, and this is now on the superficial side, you can see the trapezius, so it looks like a trapezoid, the deltoid, the infraspinous, the teres minor, the teres major, the triceps brachii we know about here, the latissimus dorsi, which is one of the largest muscles. Now on this side they cut and reflected it, but you see how far it goes down. Then you have the thoracico-columnar fascia, which is right here, and it eventually attaches to the iliac crest, which the gluteus medius is attached to. You have the gluteus maximus here. Now, going now deep, you can see for the upper limb, the levator scapulae, right up here, the supraspinatus, which is partly attached to that scapula, the rhomboid minor, right here, and to cut and reflect that, the serratus posterior superior, okay, the rhomboid major, which was also cut and reflected, the serratus anterior down here. Latissimus dorsi had to be cut and reflected just so you could pull it away and see what was down in here, because what you can see here are the erector spinae groups, which we mentioned earlier, and you know, we have some of these other ones, but they're all axial, so we've already covered those. Muscles that position each pectoral girdle originate in the occipital bone, superior vertebrae, and the ribs. To stabilize and position each pectoral girdle, the pectoralis minor and the serratus anterior work with the trapezius and the levator scapulae. The trapezius is the largest muscle in the group, and deep to the trapezius are the rhomboid major, rhomboid minor, and levator scapulae. Notice how each muscle attaches to angles to the side of the scapula. Okay, remember that we had the different angles on that scapula, the superior, etc. Well, they're attaching to it. That's why we have these sides. They're attachment sites. Again, I'm not asking you to go through lots of the insertion, although I did give some generalization there. Do know what these muscles do for action. The muscles that position the pectoral girdle. Here's the pectoral girdle. Remember that this is basically the clavicle and the scapula. So you have the trapezius here, the levator scapula here, the subclavius right here, pectoralis minor here. Yes, you've got the intercostals, both external, internal, but the muscles that position the pectoral girdle are really a group of them, including the pectoralis minor, the serratus anterior. Okay? If you do the posterior view, the muscles that position the pectoral girdle. The primary one is, of course, here for the superficial part, the trapezius. But then you get down underneath in a deep dissection. So we cut away the trapezius, and what do we see? The levator scapulae, which is right here. So it's attached to one of the angles of the scapula. The rhomboid minor, the rhomboid major. Notice how it's going to another couple of the angles here. And then the serratus anterior on this side. Okay? Now, muscles that move the arm originate on the clavicle, scapula, thoracic cage, and anterior column. We've been talking about that. We want to just make sure that we're clear on a few things, because we're going to start moving now into moving that arm as opposed to just being attached around the shoulder area. The anterior view muscles that move the arm originate from the anterior surface of the chest and the anterior surface of the scapula. The posterior view and these muscles that move the arm include the latissimus dorsi and the deltoid muscles. The smaller muscles originate on the scapula. The rotator cuff muscles and tendons form a rotator cuff. We have what's called SITS. This is an acronym, SITS. This is supraspinatus, infraspinatus, teres minor, subscapularis. I want you to review the glenoid cavity diagram for the line of force. That's the line of action that you see. The action of muscles positioning the arm can be understood once you consider the direction of pull relative to the center of the glenoid cavity. Keep in mind now, as I said before, this is a shallow ball and socket joint. So when you go through this, focus on what the bones and what the muscles do to the different parts of the shoulder. Here we have the superficial dissection, deltoid pectoralis major. Notice that a lot of this is attached to the clavicle. It is also attached to the sternum. Muscles that move the arm underneath in the deep area. The subscapularis, which is right here. By the way, you can see a clear attachment here to the humerus. The coracobrachialis, which is right this little guy right here, underneath the biceps brachii. The teres major, underneath here, it also is attached to the humerus. Then when you do the posterior view, what do you see? The supraspinatus right here onto the scapula, the deltoid, the latissimus dorsi, this huge sheet here, and then aside of it is the thoracolumbar fascia. And you notice how they're all attached nicely to these spinous projections from the vertebrae. But when you do a deep dissection, you pull away all these huge sheets of muscle. Then you see the supraspinatus right here over to the humerus. The infraspinatus, which includes 1, 2, 3, all attached here. The teres minor here, attached. The teres major here, but it's attached back over in here. All of these contribute to what are called the rotator cuff muscles. This will help you to understand this. These are the different joint movements. Extension, flexion. Adduction, abduction. Lateral rotation, medial rotation. This is the anterior, so this would be sort of the front, facing forward. This is the posterior, so this would be the back. And you can see the forces being pulled by the deltoid, by the tendons of the biceps brachii here and here, by the subscapularis, which is underneath here. Don't forget that you've got the triceps brachii, which is going to do the opposite to what the biceps would be. So the biceps would do flexion. The triceps are going to do the extension, Okay, teres minor plays a major role here, opposite to the subscapularis. Okay, teres major is over here. All right. Muscles that move the forearm and hand originate in the scapula, humerus, radius, and ulna. You need to review the muscles involved with extension at the elbow and wrist, and review the muscles involved with the flexion at the elbow and the wrist. Almost like when someone flexes their muscle and says, see that muscle, but they're also flexing at the same time the wrist, curling the hand inward, and you're going to see all of these muscles acting in a particular way. We also have to keep in mind the muscles involved with pronation, supination. That's that unique capability of rolling the hand as it rolls the ulna and the radius over each other. The muscles that play a role there are the pronator teres, which originates on both the humerus and the ulna, rotating the radius without either flexing or extending the elbow. The supinator originates on both the humerus and the ulna, rotates the radius without either flexing or extending the elbow. We also have the pronator quadratus, which originates on the ulna and assists in pronation. Here is the supinator muscle, the pronator teres. Here is the pronator quadratus. This is the ulna, this is the radius. So in supination, both of these are parallel, but what I want to do is I want to turn so that the thumb will be over here, such as what you see here with pronation. What happens? You're going to bring the radius over to on top of or superior to the ulna. Notice how these muscles had to contract and they would pull in such a way, but mind you, nothing changes here at the elbow. Okay? Now, muscles that move the forearm and hand originate on the scapula, humerus, radius, or ulna. We talked about that. But there's something you need to be introduced to, and that's called the reticulum. This is a band of thickened deep fascia around the tendons, in which the tendon groups from the different muscles pass under one connective tissue band. This is derived from the Latin verb retinere, to retain. Now we have an extensor reticulum and a flexor reticulum. The extensor reticulum holds the tendons of the extensor muscles in place, whereas the flexor reticulum stabilizes the tendons of the flexor muscles. Now, if you look here on this posterior view, here's the extensor reticulum side. If you look on the anterior view, here is the flexor reticulum. Now, if you remember situations of carpal tunnel syndrome, we're going to go over that in a minute. But let's go over the extensors and the flexors, the pronators and supinators, okay? For the elbow extensors, you have, of course, the triceps brachii, the long head, and the lateral head. Also, what provides some stability is a small muscle called the encompass. Now, notice you're going to have the oleocranon here of the ulna. The wrist extensors you're going to have are the extensor carpi ulnaris right here, the extensor carpi radialis longus right here, the extensor carpi radialis brevis, this little guy right down in here, the extensor digitorum, which is this big hunking one right here. And the interesting thing is if you follow it down to where it's tendons and then it extends over into the hands, you can, the fingers, the phalange, you can actually see how it plays a role. You've got the radius here, the ulna here. Okay, so that's the extensor reticulum. Now let's look at the other side of the coin. Let's look at the elbow flexors. Of course, that's the biceps brachii, the long head here, the short head here. The brachialis, which is underneath here and here. And then we have the brachioradialis. And we had to pull a little bit of the brachialis because you wanted to be able to see the supinator here, but still, brachioradialis, see how it goes all the way down to here. Okay? The wrist flexors consist of the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris right here. So far, so good. Notice how, again, you have these muscles these are all extrinsic muscles, because notice that their tendons will go all the way underneath the flexor reticulum and then diverge into individual phalanges to play a role in being able to flex them. Now, the elbow extensors, we saw this. This is the triceps brachii, the long head here. Both of the triceps, if you're going to have an extension, they're going to have to contract. And meanwhile, the flexors are going to have to relax. Right. Okay. Keep in mind that this short head actually goes up to the coracoprostus of the scapula, whereas the long head attaches up to the humerus. Now, we're getting down lower to the lower part of the arm. Keep in mind you've also got this medial epicondyle of the humerus right here, because that's where the elbow joint is. Pronators and supinators, we showed you here is where the pronator teres is. Here is where the supinator is underneath there. The pronator quadraticus is right here. Now, we've gone through all of this. My best information here is don't sweat a lot of this origin insertion here. Focus in on the muscles, focus in on what they do. And keep in mind these terms: extensor, flexor, okay? The pronator terms, triceps, biceps, things like that. Now, muscles that move the hand and fingers originate at the humerus, the radius, the ulna, and the interosseous membrane. You want to note that the large flexor digitorum superficialis covers the smaller digital flexors. In the posterior view, muscles that extend the fingers can be viewed only after removal of the muscles involved in the wrist movements. The deepest digital extensor muscles are those associated with the thumb. The extensor muscles usually lie along the posterior and lateral surfaces, okay? Whereas the flexor muscles are usually found on the anterior and medial surfaces. Here we have the muscles that flex the fingers and the thumb, okay? We've dealt with a lot of everything above that elbow joint, but we can't forget that we got a medial nerve going down here, and we're going to see how that plays a role when we talk about that reticulum in a minute. You have the tendon of the biceps brachii. Yep, okay, fine. You got the brachioradialis retracted. And now we're going to talk about the flexor digitorum superficialis, and notice how it basically has tendons that radiate out, except for this little guy here, which is the flexor pollis longus. Notice when we say pollis, it's really dealing with the pollex of the thumb. Oops, go back a second. We have the flexor digitorum profundus, which is right here, and you only really see it when you're deep, so you had to pull this muscle away, and you can see how it also has radiating out here. The thumb, though, is not affected. What you'll notice is that the muscles seem to play a role in controlling the four phalanges other than the pollex. All right. Now, if we go to the muscles that extend the fingers and that move the thumb, here's where we really go. If we take a look, we have the extensor digitorum and the extensor digiti minimi. In other words, a small one down here. The minimi goes down here and actually alters the direction of the pinky finger. So minimi, small finger. We have, of course, the abductor pollis longus, the extensor pollis brevis right here. And then the tendon of the extensor pollis longus is right over here. So what this is plays a role in the movement of the thumb. Now let's talk about the muscles that move the thumb. The enconuus is right here stabilizing everything. We have the supinator. We have the extensor indicis right here, ulna, Radius would be here. Extensor pollis longus, right here. Abductor pollis longus, right here. Extensor pollis brevis, right here. And then we have this tendon of the extensor digi minimi. They had to cut it. The tendons of the extensor digitorum get cut through here. Now, again, all of this origin insertion, I'm not going to hold you as much to it. The actions are important. Now, this is when we get into this reticulum and carpal tunnel. When we talk about synovial tendon sheets, they're tubular bursae that surround tendons when they cross bony surfaces. Tendons of the flexor muscles pass through the sheets as they pass deep to the flexor reticulum. So they're going to be underneath this sort of fascia. The fascia is going to be sort of the roof. The problem is that if you have inflammation of the flexor reticulum and the synovial tendon sheets, this can restrict movement and put pressure on what is also passing through that area, the medial nerve, which is a mixed nerve. It's both sensory and motor, and that innervates the hand. And this is where you can lead to a problem called carpal tunnel syndrome. This is the inflammation of the carpal tunnel. This carpal tunnel consists of the flexor reticulum and the synovial tendon sheets in that area. And it leads to tingling, numbness, weakness, and pain in the hand and wrist. Now look, tingling, numbness, pain, that's all sensory heading up that way to the brain. Weakness is the motor instructions that are going through that medial nerve, and they're being interfered on, so you can't get full strength of the fingers in the hand. So what do? Well, treatment for this is hydrocortisone shots. Now, I've had a little bit of this myself, and what they do sometimes is actually a mix of hydrocortisone and xylocaine. Xylocaine to remove the pain, hydrocortisone to reduce the inflammation. But if it doesn't work, they may have to go in and do a little cutting, and that's surgery. What they basically do is just do some slight incisions into the flexor reticulum, that fascia. They don't have to cut all the way through it, but they just basically do some smaller cuts that allow for a relief of the tension and the pressure. How does this really occur? Well, everybody would sit there and say it became common in our computer age when we had to twist our wrists and we type on keyboards, and so no. That's not just that. It's when you have repetitive motions of hands and wrists. So people working in beef processing plants, people working in putting parts into assembly lines and things like that, that's where it can also happen. So it's not just a phenomenon of the 21st century or the late 20th century with the onset of computer design and building or computer use, but it became more prevalent. But it was still there when people were doing all this repetitive motion, turning and switching, moving chicken carcasses down and, cutting and all this other stuff that they have to do on meat packing plants, etc. And that's just one place. Assembly lines also. Okay. Here is what I was trying to diagram for you, and you can see this really well. Look at these are the carpal bones, the pisiform, the trichrium, the lunate, and the scaphoid. Okay, so that's the floor. This is the roof, and this is the flexor reticulum. Now, each one of these are tendons. They have a tendon sheath, so it's a synovial sort of lining or membrane or capsule around it. This is also the median nerve. When there is, and you notice that there's only so much space in this, quote, carpal tunnel. So you start putting a lot of pressure, you start putting a lot of activity in here, and you start getting inflammation. Inflammation and irritation starts putting pressure on all the other remaining areas, including on the medial nerve. And that's when you start having the problem. Okay, so let's talk about the intrinsic muscles of the hand. These originate on the carpal and metacarpal bones and associated tendons and ligaments. Intrinsic. in the hand, folks. Extrinsic was outside of the hand, up in the forearm, etc. Okay? More powerful movements are controlled by the tendons from the forearm muscles. Extensor tendons from the muscles on the forearm dominate the posterior surface of the hand. Fine control of the hand involves small intrinsic muscles that originate on the carpal and metacarpal bones. These include the flexion and extension of the fingers on the metacarpal phalangeal joints, abduction, adduction of the fingers at the metacarpal phalangeal joints, and opposition and reposition of the thumb. No muscles originate in the phalanges, and only tendons extend across the distal joints of the fingers. So if you see here, what do you have? The lumbricals, which really, it's almost called like worms. That's where lumbrica for earthworms. But you notice that they're in here. They're not in the fingers. Everything that controls the fingers is basically through tendons and tendon sheets and everything else. In the palm of the hand, this is anterior view, you have a palmar aponeurosis right here. You have, as I said, the lumbricals, the palmar interosseous. The first dorsal interosseous is right here. The abductor digi minimi, right here. The flexor digi minimi brevis is right here. The opponens digi minimi is right here. And then they had to cut some of this so that they had the palmar brevis removed. Now, if you look here, you've got tendon sheets of the flexor digitorum tendons here, tendons of the flexor digitorum here, 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 etc. The extrinsic muscles of the thumb include the adductor pollis, right here, the flexor pollis brevis, right here, the opponens pollis, sort of buried underneath here. That's why you had to have this pulled back and retracted, and the adductor pollis brevis right here. Okay? Posterior view, you see a lot of muscles there? No. What do you see? A lot of tendons of the extensor digitorum. You do have a few. The first dorsal interosseous is here. The adductor digi minimi is right here. Okay? So this one has influence on this finger. Okay? And you have, of course, the extensor reticulum here. Again, I would encourage you to take the time to review the muscles here, but review more the actions than anything else. Okay? Now we're going to move to the lower limb. The muscles that move the thigh originate on the pelvis and associated ligaments and fascia. The gluteal group covers the posterior and lateral surfaces of the pelvis, so this includes, for the gluteal group, gluteus maximus, gluteus medius, gluteus minimus, and the tensor fasciae latae. Now, deep to the gluteal group, posterior, is 5 of the 6 rotator muscles. The obturator externus and internus. The externus is very hard to see. The gemellus, which is superior and inferior. The piriformis, and then the quadricus femoris. Muscles that move the thigh originate on the pelvis, but we have also the anterior group that we have to look at, and this is the iliopsis and the adductor group. Now, the adductor group consists of the adductor brevis, adductor longus, and adductor magnus. The pectinus and the gracilis are also in this group. The iliopsis is really the iliacus and the psoas major. They bring them together. The iliotibial tract, or the iliotibial band as it's called, is a longitudinal fibrous reinforcement of the fascia latae. Okay? The action of the IBT and its associated muscles is to extend, abduct, and laterally rotate the hip. In addition, the IBT contributes to lateral knee stabilization. We'll show you that when we get to the knee. But remember that when we talk about the knee, it is a remarkable, capable joint. But you can't have it going sideways. It can only go in one axial. Okay? Here we have the iliac crest. You can see the sacrum, and you can see the gluteus medius, the gluteus maximus, and the gluteus minimus, which has been covered by the medius and the maximus here. That's why they had to cut them and retract them. You also have the tensor fascia latae right here, and you have the tibio-iliac tract right here. Then if you look beyond the gluteal group, which of course I've shown you, gluteus maximus, gluteus medius, gluteus minimus, tensor fasciae latae, you have to start dealing with the iliopsis group, which is the psoas major here, from the lateral down over to attach to the femur, and the iliacus, which is on the inside here, but it does have some eventual attachment down here to the femur. You have, of course, the inguinal ligaments. You have the piriformis, which is attached here and then down to the femur. The superior gemellus, the obturator internus, which you can see right here, the obturator externus, which is over here. Notice that it is also attached. The inferior gemellus here, the quadratus femoris here, the ischial tuberosity, of course, is right here, and we have the gracilis here, the adductor magnus, which is here and here. Okay, so it's hidden behind partly the adductor longus and the adductor brevis. Okay. Now, again, in this case, get down these groups. Who's in each of these groups? Get down the actions. Don't sweat the origin and the insertion. Muscles that move the leg originate on the pelvis and the femur. Now, the flexors of the knee originate on the pelvic girdle and extend along the posterior and medial surfaces of the thigh. These muscles consist of the biceps femoris, semitendinous, semimembranous, sartorius, and popliteus. The extensors of the knee originate on the femoral surface and extend along the anterior and lateral surfaces of the thigh. The rectus femoris, and then you have the vastus group, which is the intermedius, the vastus lateralis, and the vastus medialis. Now, all four knee extensor muscles are called the quadriceps femoris. Okay, so all of this is also going by the name the quadriceps femoris, and all four muscles insert on the patella via the quadriceps tendon. So we're going to look at the posterior and then the anterior view of this thigh going into the knee area. We've seen the gluteus, the tensor fasciae latae. You can see where we have the iliotibial tract. You notice how it comes down here. But let's talk about some of these other muscles. The gracilis is here. The biceps femoris is right here. Semitendinous, semimembranous behind here, right? So membranous is partly behind the tendinous. And then we have the sartorius, which goes over the cross. Here's the sartorius here. And then the popliteus, which kind of connects from the lower part here up and around. Now, if you take and look at the front side, we've already dealt with some of this, you know, the iliopsis, which of course is the psoas and the iliacus, the inguinal ligament, etc. Tensor fasciae latae, here it is, up against the iliotibial tract, the gracilis, the adductor longus, the pectinus. Now we get down here, and now this is where we're going to have the quadriceps femoris. The rectus femoris, the vastus intermedius. This lies deep to the rectus femoris and vastus lateralis. Okay, so it's going to be underneath this muscle right here. Now, the vastus lateralis and medialis, really easy. The medius is going to be on the inseam. The lateralis is going to be on the outward side. All of them come together to the quadriceps tendon, which is attached to the patella. Then we have the patella ligament attached down here to the tibia. Okay? Here, I would like you to focus in on, again, most of the muscles with their action. Okay? A lot of the insertion and a lot of the origins have some duplication, as you can see here and here. Okay? Muscles that move the foot, toes originate in the tibia and the fibula. The largest muscles associated with the ankle movement are the gastrocnemius and the soleus. The ankle muscles are divided into flexors and extensors. The flexors consist of the tibialis anterior, fibularis tertis. The extensors are the gastrocnemius, fibularis brevis, fibularis longus, plantaris, solus, and tibialis posterior. Now, the muscles that move the foot and toes originate here, but we're also going to mention that the muscles acting on the toes are divided into two groups: the digital flexors, the digital extensors. We have the flexor digitorum, the flexor hallucis longus. Now, if you look at both of these, you can pretty much figure out the names. This is for all the digits in the toes. This focuses on the big toe. That's it for flexors. The extensors, to the same degree. Extensors, these are going to handle the rest of the toes. This focuses only on the big toe. Now, ankle extension is important for running and walking. Muscles that move the toes are smaller and originate on the surface of the tibia, the fibula, or both. You have tendon sheaths that surround the tendons of the tibialis anterior, extensor digitorum longus and extensor hallucis longus, crossing the ankle joint. This is where you have to think about this. You have some stabilization so that you can have the tendons go down at an angle from the ankle and then go into the foot and eventually into the toes. The stabilization of these movements is by the superior extensor reticulum and the inferior extensor reticulum. Again, know the groups, know their action, don't sweat the origin and insertion. Let's take a look at the groupings here. From superficial dissection to the deep dissection. Here it is on the posterior side. I have the plantaris here, which if you look deep, it goes all the way down with a very long tendon. The gastrocnemius here is attached back to the tibius, but then has a very long tendon called the calcaneal tendon, which we also call the Achilles heel tendon, and it's attached to the calcaneus. If we cut and remove the gastrocnemius, we have another muscle underneath here, the soleus. Okay? Now, if we go further in our dissection, so that we now are able to basically do somewhat the extension and flexion, okay? The ankle extensors are going to be the tibialis posterior here, and here, and here. The fibularis longus, which is here, fibularis brevis is this tiny guy over here, and then we have the digital flexors, which are this, which is the flexor digitorum longus. The flexor hallucis longus has got to be right over here. And then we have the tendons of the flexor digitorum longus, and you'll notice that they go down, and here's where we get the difference. Digital longus goes into the digits, does not go into the big toe, the hallus. Okay? All right, the tendon of the fibularis brevis comes down here. The tendon of the fibularis longus over here. Okay? Notice that these are crossing over in such a way because they're going to help also contribute to the arch of the foot. Now, you have lateral view, medial view, anterior view. Ankle extensors. The gastrocnemius, the fibularis longus, the solus is between them. The fibularis brevis is on the side here. This is our superior extensor reticulum, so the tendons will come down through here, get rerouted. Underneath this is the inferior extensor reticulum. Okay. Now, the tendon of the fibularis tersus is right here. Notice the big toes over here. That's where we have the tendon of the extensor hallucis longus. This is the long one that comes down here for the toe, the big toe. The extensor digitorum longus is right here. Okay, we have the ankle flexors, which are the tibialis anterior here. Of course, you got the patella, the patellar ligament. You can see this is the medial surface of the tibial shaft. Ankle extensors. We're going to have the gastrocnemius play a role, the soleus, the tibialis posterior right here. And then we have, of course, the superior extensor reticulum, the inferior extensor reticulum. Then you have the tendon of the tibialis anterior here. Okay? You see where that comes down here. Then you have, of course, the extensor hallucis longus, comes down here, and eventually comes to the hallucis, which is the toe. Okay? Extensor digitorum longus is here, the tibia, tibialis anterior, fibularis longus over here. Why do we put so much attention into the ankle flexion and extension? Because this plays a role in one of the reflexes we monitor, and it's also a unique movement. Dorsiflexion, plantar flexion. Plantar flexion is the same thing as saying ankle extension. Dorsi, ankle flexion, and you're curling upward. Extrinsic muscles of the foot originate on the tarsal and metatarsal bones and are associated ligaments and tendons. The intrinsic muscles are more numerous on the inferior, that's the plantar surface of the foot. The reticula play a key role in stabilizing the tendons descending from the leg. The intrinsic muscles consist of the extension and flexion of the foot. These include the flexor hallucis brevis, the flexor digitorum brevis, the quadricus plantae, the lumbricals, there's 4 of them, the flexor digi minimi brevis, the extensor digitorum brevis, and the extensor hallucis brevis. Now, the only other thing we have to really talk about for a second is adduction, abduction of the foot. We have the abductor hallucis, the adductor hallucis, the plantar interosseous, there's only 3 of them, the dorsal interosseous, there's 4 of them, and then the abductor digi minimi. Keep in mind several of the terms. If you're situated between bones, we call that interosseous. So the plantar interosseous are going to be actually located between some of the bones. And we'll get into those in a second. The great toe is the hallucis. Okay? So, again, review the names, review their actions. Don't sweat as much about the origin and the insertion. This is a view, and let's take a look at the intrinsic muscles of the great foot. Here we have the extensor hallucis brevis. Okay? Notice that it comes over, and this is the large toe here. Here's the hallux right here. So it's going to attach to this sheath right here. And this is also the tendon of the extensor hallucis longus right here. We have underneath it the abductor hallucis. Okay. We have also a couple of other little structures here. By the way, this is our superior extensor reticulum. This is the inferior extensor reticulum, the lateral malleolus of the fibula, the medial malleolus of the tibia, the tendon of the tibialis anterior. Now let's go through toes 2 through 5, okay? The dorsal interossei, here, so it's between the bones, and the tendons of the extensor digitorum brevis here, here, here. Okay? All righty? Okay. Now, if you look underneath, okay, posterior view of the foot, you see a lot more what we would call the fleshy part of the foot. This is where you're going to have these fibrous tendon sheaths here again. This is where you're going to see the lumbricals. Okay, remember this is the big toe, the hallux. These are the smaller toes. Okay, so what do you see? Okay, you have a plantar aponeurosis, which has been removed. You got the calcaneus here, so you can get some navigation. You have the abductor digi minimi here and here. They're going to come over and serve the little toe. Okay, so digi minimi is going to be for the little guy. Okay, we have the tendon here of the fibularis longus. We've got the tendon of the tibialis posterior here. We've got the tendon of the flexor digitorum longus here. Okay, so they're coming underneath here, but this is deep. Let me move back here and just stay with superficial for a minute. Here are all the lumbricals that you saw earlier. Okay, here's the flexor hallucis brevis. Hallucis, they're all going to just serve that big toe. The flexor digi minimi here, it's going to serve that little toe. Everybody in between, you've got the lumbricals and you've got the interossei. You've also got the abductor hallucis here, the quadratus plantae, which is really a deep muscle here. The flexor digitorum brevis, notice that it goes under all four of these toes here. Okay? And when you go to the deep, you see all the tendons of the flexor digitorum brevis. Yeah, they actually cut those away. So you can see clearly the lumbricals, the flexor hallucis brevis here, the flexor digiti minimi brevis right here. Okay? The abductor hallucis right here. They had to pull that away. We get to see that tendon of the flexor digitorum longus. The quadratus plantae, which is right here. Okay, and you can see the flexor digitorum brevis right there. Okay. All of this to help you is to think about one or two other things. Why is my foot not like my hand? I don't have as much of the movement. I've got a lot more of the control of the movement of the toes controlled by the lower foot than I do by the movement of the hands, etc. In other words, I can't put this toe over and touch that toe over there, opposition, that I can with my thumb and my forefingers. Okay? So there's a lot less musculature to allow for interaction of the different digits here than there is for the fingers in the hand. Now, let me just go over some other important points. The deep fascia, which divide the limb muscles into separate compartments, there is a fascia review which is on page 169 of the text. And if fascia is a little bit fuzzy in your memory, go over it. Fibrous partitions of deep fascia form intermuscular septa. In other words, these sections or divisions. And they separate muscles into sections called compartments. Muscles within these compartments have similar functions. In other words, either extension or flexion, etc. And as well as the blood and nerve supplies. So it's almost like they are separate organs separated by the surrounding other muscle organs by this fascia barrier. Now, because of this structural separation, infections or excessive pressure can be sequestered to the affected compartment. And this is where you get into what's called compartment syndrome. Let's say you have trauma, and then you have the subsequent bleeding. You're going to have elevated pressure in the compartment that can compress the blood vessels and nerves in the compartment. This can lead to ischemia. In other words, Literally so much pressure builds up that the blood vessels get flattened out, compressed, and they can't deliver blood any further. So you get blood starvation, ischemia. Now, this condition can lead to paralysis or death unless the pressure is relieved within 2 to 4 hours. Sometimes what they literally have to do is go back to that area and slice a little bit into the muscle to just release the pressure and allow for blood flow. If you have death of the muscle, you're going to have a tremendous amount of potassium released. This potassium can lead to a heart attack, can trigger cardiac and MI. And so it's very important to deal with compartment syndrome as soon as it is detected and to release that pressure as quickly as possible. As you can see, here's the compartments here. Look, here's a compartment right here. Here is another compartment. So you've got the superficial anterior compartment here of the flexor digitorum superficialis. You have also another one right around here, and notice that this is partly what you have is the radius and the ulna. Okay, and you can take the same thing and say, well, what about the triceps brachii? Yep, right here. This is an entire compartment here separate from the biceps brachii and the brachialis. You notice within this compartment also are blood vessels and nerves. Okay, you can go up to the deltoid area where you have the triceps brachii here, part of the biceps brachii here, a large section of the deltoid. If you ended up with a crushing wound or a damage, you can end up with excessive bleeding in there that can basically be contained inside of that compartment and yet build up pressure and block any blood flow going through that area to subsequent structures inferior to or superior to that injury. Now, I'm not going to have you memorize all of the compartments, so you don't have to worry about that, but I would encourage you to get familiarized with them because they do play a key role in understanding where damage can occur, trauma can occur, and what will be the result of it. So we've pretty much covered this all. This is great. I encourage you to peruse the chapter review outline on pages 397 to 399. Complete the review questions 399 to 400. Complete the review sheets on 358, 372, and 396. Now, one other thing, don't forget the end of the chapter sheets that are present in the Blackboard. These are the PDF sheets. As well as I encourage you to take time, if you have to use basically the flashcards, Quizlets, index cards, for not only the terms and then what they mean, but also where these muscles are located, etc. It is going to be absolutely essential that you have this for the upcoming exams. Our next chapter will focus on nervous tissue. And I hope you have a great day.